Awesome. Thank you so much, Caitlin and Vania, for inviting me to co-present today, and for everyone taking your Friday morning or afternoon, wherever you are, to be with us. Let me share my screen, and then I'm not going to be able to see you guys again. So go in presenter mode. Oh, no, that wasn't it. Oh, where are you? Share. Okay, can everybody see and hear?
You are
amazing. Oh, I can see Caitlin, great. Okay, I'm not speaking to the void. So I'm Dr. Jessica Gray. I'm a family medicine and addiction specialist out of Massachusetts. I am a perinatal addiction doc at the Hope Clinic, where we care for pregnant patients and postpartum patients at Low Threshold Bridge Clinic, as you may have skimmed in my bio, and work doing some consulting work for the state through the Mixed app, which I'll share about briefly, as well as the current president of the Massachusetts Society of Addiction Medicine. And I'm just going to pass it to Vanya to introduce herself before I kick us off.
Hi, everyone. I'd like to start with a big heart to Caitlin and Jess and all of you for being here. I work in Seattle, also board certified family medicine, addiction medicine. And for the past few years, we very passionately have been advocating to improve services for methadone dose and recognize it as an evidence-based medication. So we look at this conversation as a chance for us to share information, experience, and to learn from each other. Thank you.
Awesome. Okay, so I'm going to drive this. We don't have anything relevant financially to disclose. And I want to start, we're going to start with Massachusetts and then flip to Washington State, but just to sort of frame the big picture, why we're here, right? Mostly because of illicitly manufactured fentanyl in the drug supply. It's actually not new in Massachusetts and probably for a lot of states, right? So I think by 2018, it's something like, 90% of samples of heroin were saturated by fentanyl. So it's been there, it's been here for a while. And our historical methadone dosing has not been sufficient for quite some years around helping pregnant patients stabilize. And it's not just the fentanyl, right? It's sort of the consistently changing drug supply that is hard to keep up with. And I've learned both from colleagues, across the WAG and through our own practice that start low and go slow. It just is not effective in pregnancy and stabilizing a pregnant person on methadone. And so the sort of historical approach really led to a lot of in-hospital drug use for our patients as we try to stabilize them, self-directed discharges because they weren't being adequately treated, and really an inability to stabilize on the medication that we know can work so well. Some of the other barriers were just the complete lack of inflexibility of being on methadone, right? So people were shackled to coming daily. They would have to stand in line with pregnant with their newborns. They often had to decide between a job and earning take homes, and so it also made it practically inaccessible. And then with fentanyl, we've all been living just the sort of real challenges of getting, especially pregnant folks, on buprenorphine without some heroic efforts. And so I just wanted to frame that those are not new challenges, but ones we've been grappling with in Massachusetts and other places for a while. And so I thought it would be helpful to frame this conversation. And I do hope that we hope to really have a conversation at the end around what it means to rapidly stabilize someone, or what is needed, I should say, to rapidly stabilize someone in pregnancy on methadone. And it requires a change to the entire continuum of care. And so while we're going to be talking about dosing, I thought it would be really helpful to reflect on some 4 changes that have occurred over the last few years and that have really transformed Massachusetts' approach to stabilization in trying to put this together for you guys. And so the pieces I want to talk about are the implementation of the updated federal regulations, at opioid treatment programs and how Massachusetts sort of interprets and goes beyond those, the federal 72-hour rule expansion for methadone, some of the evolving antenatal hospital titration practices in our state, just some sample, and then in our state, thinking about how mandated reporting really has also impacted methadone stabilization. So that's my itinerary with you guys. So just starting with our federal regulations. So SAMHSA put out what's called the final rule, or the 42 CFR Part 8, which really was the first time in 25 plus years, right, that there were changes to methadone regulations. And this has really been the single biggest change in decades. And what it did was really codify a lot of the COVID era flexibilities that we saw that proved to actually be, helpful and not dangerous in terms of take homes and dosing changes, made those permanent. It replaces, I don't know if everyone's familiar with this, the sort of 8-point criteria, which used to be a pretty enormous hurdle for opioid treatment programs to actually, increase or provide split dosing or take homes for patients. And so what the final rule said was that it allows up to 7 take-home doses within the first 14 days of treatment, and you can start those take-homes potentially on day 1. Maintains that the ultimate decisions of dispensing and doses really rest with the opioid treatment program medical practitioner, and that's a really important point as we sort of think about the variation in practices. It importantly for our population, it confirmed that split dosing is distinct from take-home dosing, that should be guided by clinical judgment, and reduce barriers to admission, such as the old requirement that you have to have a year of diagnosed opioid use disorder. And also helpful for our population is that it expands the ability to do telehealth for initial evaluations and ongoing care. Again, if someone simply can't get in to see the practitioner. What it doesn't address, though, is methadone titrations, like dosing. And so I just wanted to review that with you all, because that hasn't changed since 2021. So the federal rule, which is based on the FDA labeling of methadone, and it's also in 42 CFR Part 8, states that the first aid dose in general is 30 milligrams, unless there's documentation of an exception, such as, significant dependence, right? And so, and then they the recommendation is you can go up to 40 milligrams cap. What it doesn't detail out is sort of the approach after that. So there's no fixed limits written in the federal rule on how quickly you can go up, but whatever you do needs to be clinically justified, safe, and documented. And so that's the federal rule. In terms of looking at Massachusetts, just this past July, actually. So again, the federal states then can interpret the federal rule. They have to abide within it, but then they can sort of extend it, be more or less, or I guess be more strict or rigid. And then the OTP itself can then make additional laws. So or practices. And so in July of this past year, our Bureau of Substance Addiction Services actually explicitly said that the first aid shouldn't exceed 50 milligrams unless there's sufficient medical rationale. For example, patient transferring, or if they didn't suppress withdrawal. And I know that seems maybe small to some people, but actually that really sort of pushed more OTPs to be comfortable starting at higher doses than I think they would with just the federal rule there. Again, they require really clear assessment and justification of why a higher first aid dose is needed, but that it's perfectly allowable. So again, you can go above 50 with clear documentation. And I guess I just shout out here for one more second is the reason these things are possible is because addiction experts, perinatal experts, and others in the medical field really work in partnership with our SOTA, the State Opioid Treatment Authority. And so if you don't know your SOTA, it's a wonderful sort of advocacy tool to really connect and learn from each other, because they are the ones that directly uphold and make the state regulations on methadone. And we have a phenomenal team with Jen Babich and Mike Gurney in our state. Okay, so that was just a little whirlwind through our OTP changes. In terms of the 72-hour rule, and so this is just copied from a descriptor of it, right? So this has been around for a while, that you can dispense or administer methadone from, for example, an emergency room. But what changed in the last few years is that non-OTPs, non-opioid treatment program physicians, emergency departments, bridge clinics, for example, or hospitals can administer up to 3 days at once, rather than just daily dispensing, while you're arranging for a linkage to an opioid treatment program. And the reason behind that was really to provide more immediate stabilization, right, to facilitate this smooth transition, again, in the setting of needing to improve access to OTPs. And so while I can't speak to the whole state, I can share what we do at our bridge clinic where I work. We've been doing 72-hour methadone for quite at least a year or two now. It is incredibly helpful because it allows us to really own the clinical decision-making on dosing. So for someone, for example, who has a high tolerance, who doesn't have, contraindication to rapidly titrating on methadone, we start them on 50 or 60 on day one. By day 3, we're up to 80 or 90. And that way, when they then directly link on day 4 to a methadone clinic, not very few of our clinics have daily admissions. And so they basically, this allows someone to sit at a more therapeutic methadone dose while they're waiting for sort of the next steps of coming into the methadone clinic, getting the evaluation, getting all their paperwork done, sort of all those processes to be considered like fully admitted so that they can get their dose changed. So while some methadone clinics are able to then, get all that paperwork done day 1 and continue on, others sort of get stuck on whatever dose they come in on. And so the ability to be on a more therapeutic dose has been really important. And so we do this for pregnant patients, for non-pregnant patients, and are really able to, again, more quickly stabilize in an outpatient setting. And so that is how we are currently utilizing the 72-hour rule. And you'll hear more from Vania on how they're doing it in Washington. And so then what you thought you were probably coming to talk about, which is hospital-initiated methadone, right? For those of us who don't work in an OTP or bridge clinics, how are we caring for our pregnant patients who want to initiate on methadone? And I don't have sort of comprehensive data to share from Massachusetts, but so I think there's an opportunity we can talk about with WAG to think about really how we can help move the entire country forward. But what I can share is a sample from my hospital of an OB-driven inpatient titration protocol that we developed. And so in 2023, we were realizing that our hospital heavily relies on our incredible addiction consult service, but it's a very big hospital and they're not able to be everywhere at the same time. And so we would have pregnant women come in and they had a delay to getting their first doses of methadone and to getting stabilized because the OBs just weren't as comfortable doing this since we had this amazing service. And so we really wanted to empower our OB teams that they could actually initiate methadone, get patients quickly comfortable without needing to wait for the addiction consult, which could sometimes take hours. And so that's where this was born out of. What I'm going to show you is actually just for the first 24 hours, because ideally by then our addiction consult takes over and continues with further assessment. There's 3 parts to the titration protocol or 3 branches. I'm going to show one of them, but essentially the point of contact is a patient coming in withdrawal, wanting to get comfortable whether or not they want MOUD long-term. And so we have a sort of a branch for a patient who's new to medication for opioid use disorder who wants to get on methadone and stabilize there, who's new and just wants to honestly get out of withdrawal and they're not sure what they want to do. And then one pathway for or initial pathway for someone who wants to be on buprenorphine but is in active withdrawal and wants to get comfortable. And so those are the three. And I'll say that this is probably going to fall out of use because we're working on a Mass General Brigham-wide protocol, but currently this is sort of what we're helping our OB teams work with. And so just to briefly go through it, and I'm sorry if it's small, I blew up some of it in the next pages, but we have an opioid withdrawal order set that lists out comfort meds. We ask to order an EKG, but it's not required to start. Put the ACT consult in. If you're going to offer a toxicology test, we need to have written consent in our hospital now. And then the fetal assessment. And then essentially the goal is to get patients as stable, as comfortable as possible quickly based on their withdrawal scores. And so we ended up using sort of breakdown of COWS, right? So mild, moderate, or severe withdrawal, and started at 20, 30, or 40 milligrams of methadone with a Q4-hour evaluation. However, in yellow, right, if the patient's still in active withdrawal 2 hours post the initial dose, we continue with either more comfort meds or methadone at the rates that I showed here, up to 10 or 20 milligrams. And so someone may, within the first 2 hours, right, potentially get up to 60 milligrams, and then continue with opioid withdrawal monitoring and scoring with additional methadone every 4 hours. In this case, again, thinking that this is really just the first day of before ACT comes in, people may, be on low dose if they are unusual but don't have much tolerance or experience, versus really up to 90 or 100 milligrams on that first day. And then again, just some more information about our protocol is, we consolidate the dose the next day, save a little bit for the evening as people are thinking about whether they're going to do split dosing, and just wrote some helpful tips for our providers, again, who are not in this field directly. So thinking about, continue to use comfort meds with the medications, asking patients about their last use, and thinking about other co-occurring withdrawal that may complicate the picture. And again, reminding folks that we anticipate more rapid methadone metabolism, especially as they're in their third trimester. And so again, that's just sort of a snapshot of one example of trying to get people rapidly stabilized that first day and then continuing up. And I'll say that, again, across Massachusetts, hospital methadone titrations vary in pregnancy and outside of it. There's a wide range of titration protocols, not surprising. Some places still don't have them. The hospitals, I think, that are most struggling don't have addiction consults available or addiction expertise available. And so we do see, especially in pregnancy, transfers into our hospital, for example, to help stabilize. And then with all that, if you don't have a relationship with local OTPs to connect afterwards, this falls through. And I'll say our hospital, sort of at the same time we were doing this, really liberalized and became more aggressive with methadone titration in the general population, not just in the pregnant population. And so our ACT team, for the right candidates who are appropriate for a rapid stabilization, do go up to 90 in the first day and then continue. Okay, my last sort of whirlwind through Massachusetts, changes in Massachusetts that have impacted methadone titration is this lovely schematic that Davida led on a qualitative study we did out of MGH, looking at the negative impact of mandated reporting policies on prenatal substance use. And so for the last 7 to 10 years, I think there's been a lot of advocacy work in our state to try to repeal or remove the interpretation of federal CAPTA and CARA as requiring a Department of Child Welfare referral or report of abuse and neglect for patients who are on medications for OUD. And we were seeing that it was keeping patients out of care and keeping patients off of MOUD. And so why is this here? Because again, in our systems, if we don't have a safe place where people can feel comfortable getting on medications, who, are not worried about sort of being policed because of those medications, right? We're not going to be able to get people into care and get them rapidly onto methadone. So I'm really excited to share that almost a year ago, Massachusetts signed a law actually updating this policy. And so we now no longer need to sort of automatically report a parent who's in recovery from substance use for abuse and neglect. We don't always need to get the child welfare system involved. Some hospitals, including my own, had been working towards this anyway, but really a huge thing for our whole state that we're able to really change how we approach this. And it absolutely has had a trickle effect on patients being willing and to stabilize rapidly on MOUD. So I'm going to just summarize all those pieces in terms of thinking about the challenges and opportunities in Massachusetts. And, in these 4 buckets, right, thinking about opioid treatment programs, it's wonderful that our SOTA and many programs actually push the envelope in terms of helping pregnant and other patients really stabilize faster as outpatients. And I think, again, something to think about as the whole continuum of care needs to support rapid stabilization. And so, we both have a lot of forward-thinking OTP medical directors who are really rapidly titrating up, immediately offering split dose in pregnancy, going up by 10, to both morning and evening dose, right? Knowing that they're rapid metabolizers so going up 20 milligrams a day and in the outpatient setting to really stabilize pregnant patients. But not all of them, right, are as forward thinking. So I think we have a lot of work to do there to get everyone on the same page. Also, tremendous operational funding challenges in our opioid treatment programs, right? So splitting, I've yet to have an OTP be able to actually split someone into 3 time-a-day dosing, just because it is such an administrative and a burden on nursing. And so even the most forward-thinking treatment programs really are struggling with how to, within the confines of their system, be able to actually split the dose as many women need, more than BID dosing in pregnancy. So that's been a challenge. And again, until methadone reimbursement is not aligned with this patient-centered care, I think we're gonna be really in a spot. In terms of 72-hour methadone, I think it's been a wonderful tool for allowing for more rapid stabilization, for even if patients not ready to go into the hospital, to get them a little bit more comfortable and then having them go in that day or later that day. So again, really helpful, has been required a lot of OTP collaboration. And so it's something that I think takes work, but is really worth it. And then, I think we have a lot of room in terms of how we think about rapid hospital titrations and think about how WAG can sort of guide all of us on making these more evidence-based and better. And then I'll end with just a couple of pieces around the education and advocacy work we've done in Massachusetts. So I said I've been on the board of MASAM for a while now, and we have spent a couple of years really focusing on modernizing methadone. This is a sort of a series we began within our annual meeting to really think about how we bring all these players to the table, and meet all the OTP directors and clinical directors, meet each other, become familiar with each other, learn from each other, and learn from our state opioid treatment authority, who has come to every one of these meetings. Really covered key areas of innovation. The favorite is really bringing the flash round. So each of our OTP directors actually shares what they've done in their OTP this year to really make patient-centered care better. And a plug that this is free for all of you and anyone who wants to watch these. We put them on YouTube after. So we now have 3 years of really great lectures there if folks are interested. I'm also part of MIXTAP, which is a state-funded consultation service for treatment of addiction and pain. And we just started collaborating with MCPAP for Mom, which is our sort of perinatal psychiatry arm of this resource for statewide for practitioners specifically who have questions and want to ask about perinatal mental health and substance use disorder. So really excited to think about how we leverage, again, more training and build our knowledge base as a state. I think Davita's on, but she's really been working with the Perinatal Neonatal Quality Improvement Network on the Perinatal Opioid Project for several years now, and that's a really exciting quality improvement collaborative around our state that has worked again on methadone in part. And then our Bureau of Substance Addiction Services has continued these sort of longitudinal statewide methadone learning collaboratives that have been really valuable with getting people up to standards of care. And of course, we're now working on how we actually implement the new reporting law. That's being led by our Department of Public Health. So I'm going to turn it to Vania after that to talk about Washington.
I want to take a moment and say big thank you to Jess. What a great presentation. To appreciate modernizing methadone, and also a hard, just act to follow. So I will do my best to talk how we embrace methadone in Washington. And Jess shared how important it is for state addiction medicine chapters to be involved in legislature and work. Very similarly in Washington, for the past couple of years, we have been working with our legislature, the healthcare authority, the Washington SARA, to embrace methadone, to decrease the stigma to it as a medication, and to allow in an ambulatory and inpatient setting methadone to be prioritized as an equally evidence-based medication that improves and saves lives. As you can see here, we were able to approve 2 budget provisos that were part of the opioid settlement funded legislative proviso. And we had $2 million that was dedicated to create an inpatient rapid methadone stabilization pilot program that included split methadone dose pathways, clinical pathways, choices also for different frequency, in addition to 72-hour methadone dispensing, also prioritizing and highlighting opioid overdose, educating patients while they're at the hospital, the ability to give them an naloxone take-home kit to take home, in addition to sending a prescription to the pharmacy. And Jess will be flipping through slides very fast. Here, we have created a methadone proviso policy. We have been working with our perinatal collaborative. We do have a guidance and a document that will be published in our state, and I'm more than happy to share it also with you or anyone who would be interested. We also have developed consultation listserv and peer support line. It's called Yes We Can. As you can see, this is something that I have created because I truly believe that we can make a difference, and our patients usually reassured us that we are available to be good listeners, to be present, and also to allow them to feel empowered to improve their general health. A little bit more about Washington State. As part of our legislative effort, earlier this year, we wrote and presented a WSMA C-15 resolution that is dedicated to support for inpatient rapid methadone stabilization for pregnant and postpartum people, allowing any birthing person who admits at any hospital in Washington State, and we have total of 94, to be able to be offered education and choices for methadone treatment. Washington has total of 53 birthing hospitals, and we currently are implementing a split methadone dose pathway with 72-hour and naloxone education in all 53 birthing hospitals. Jess, you can flip. I heard how amazing Massachusetts as a chapter is doing. I also would like to share with you that in Washington State, we have been working with our OTPs, and currently for any pregnant person, they can be offered a higher dose to start at in a methadone clinic, such as 40 or 50 milligrams. Usually this is a clinical decision, as Jess highlighted, that needs to be documented. Washington State does prioritize the importance of perinatal population. We also just recently developed a new requirement, and we have formal 24/7 a hotline for each OTP that verifies the dose. As a clinician, I find that in the past it was very challenging when you have, for instance, a pregnant person arriving in triage who is on 200 milligrams of methadone dose, and we cannot access care and verify the dose. And sometimes it does create clinical challenges. This is something that, thank you to the Healthcare Authority and the Washington SOTA, is now available, and it makes warm handoff and clinical care much faster. And we also have a requirement for infectious disease screening, such as hepatitis A, hepatitis B, hepatitis C, HIV, syphilis, and there is an increase in treatment after we implemented that. We also have new methadone services available, such as mobile medication units that also offer methadone split dosing for perinatal people. And most recently, as you can see here, we were the state that had the highest number of OTP mobile medication units in the nation. So something for you to consider. As you can see here, we do have a high dose methadone stabilization. We start usually 30, 40 milligrams as a low dose. We do allow people to have as needed doses. Sometimes it's every 4 hours, every 6 hours. Very similarly to Jess, we start with the main dose to be offered in the hospital at 6:30. We find that offering that dose before nursing shift changes allows patients to receive their first dose of methadone without having to worry that the dose will be delayed. It also supports nurses too, and we need to be very thoughtful around whole person approach for medical staff, nurses, and patients. And I do have a couple of slides here that I would like you to appreciate. This is the methadone pathway for rapid and moderate methadone dose. People who have severe opioid use disorder, who use more aggressive fentanyl. Currently, it is the powder or the rock, more than 2 grams. We usually can start with a higher dose, and this slide shows the moderate and the rapid methadone dose for people who have moderate opioid withdrawal opioid use disorder, in addition to using smaller amount of fentanyl, such as maybe half gram of fentanyl powder or rock per day. We start slower at 20 milligrams. As you can see here, we offer as needed doses. Supportive meds, very similarly to Jess, it could be scheduled or as needed. And sometimes people also need hydromorphone in addition to allow them to, just get better relief from severe withdrawal symptoms. The adjunct, the supportive medications that we offer, as you can see here on the bottom of the slide, and the next slide will show you the high dose methadone clinical protocol. As you can see here, it's a much higher. You can start with 40, 50 milligrams. You could be up to 90 milligrams per day. Sometimes people would feel so severe and intense withdrawal symptoms that we will need to also offer an extra 1 methadone dose if the person is evaluated by a nurse or a physician. How does that look like in daily life? We do have initial data to show that we had 79 people who were offered high-dose methadone stabilization, 72-hour methadone dispensing with overdose education, prevention, and naloxone take-home kits. As you can see here, there is a big range how many people need lower dose versus a higher dose of methadone. Sometimes we would also require, nowadays we are seeing much higher split methadone dose. People completed their treatment and everyone chose split methadone dose. There was one person who did not know whether the dose would be continued. And in Washington State, as of now, all of OTPs offer split methadone. Those are very supportive of that. We offer the 72-hour methadone dispensing. In addition to that, methadone lock boxes, offered Narcan take-home kit dispensing, and we were able to save 135-day reduction in length of stay. We also allowed for linkage to care. None of the people who were discharged from our hospital admitted to the ER within the next 30 days. None of them had overdose or were very sick with untreated other medical complications. And people felt very satisfied with the treatment that they received. Next slide. Here, something to allow us to appreciate our community building. As Jess pointed out, WAG has continued to be a family where all of us continue to learn. We have the Choices website. We also, for the past few years, have been offering free summits. And this is the last summit that most of you actually attended. That happened last year in October, as you can see here. We did the pre and post summit evaluation. And we have statistically significant results for compassion, stigma, with how pleased people are that they received up-to-date treatment, appreciating evidence-based approaches, and also thinking of utilizing strategies to reduce stigma, bias, and barriers. If anyone has difficulty with methadone initiation, feel free to call our Yes We Can line. We are here to offer support. And the last one is the voice of a person who received high-dose methadone twice daily stabilization, who was able also to go back home and receive 3 days worth of methadone, in addition to feeling that she was treated with respect and she had a much better chance to have a healthy baby. And I will give it to Jess.
Thanks, Vania. I debated sharing this case because it's complicated, but Vania said keep it in. And so I just want to end with just a complex recent case my patient gave permission to share. And hopefully this will spark sort of our, the next 15 minutes we can really, think about together how we navigate some of these, complex initiations, or think about sort of what's going on in other states, and maybe what we can do at WAG. So bear with me for a whole words, but so this is a 26-year-old. She's got sickle cell disease, which is pretty significantly complicated by femoral avascular necrosis. She's got osteonecrosis, severe complex chronic pain. She's been followed by our hospital sickle cell team for years, obviously because it's a childhood disease. She was admitted for a sickle cell crisis and was found to be pregnant about 4 months, and sort of was newly identified to be using non-prescribed pills, which were found to be prostafentanyl for her uncontrolled pain, despite being on prescribed moderate to high dose of oxycodone from her hematology team, and didn't have a known prior substance use history before this. She had a very long, month-plus long hospitalization for stabilization of her pain that really was complicated by high opioid tolerance. Some of the sort of debates that went on were around whether, this was undertreated pain. Is this, opioid use disorder? The addiction team was very involved and recommended that she get started on basal methadone. And ultimately, the decision was made for her to transition to a basal pain methadone and short-acting oxycodone for breakthrough pain. And so she was discharged on outpatient methadone with the idea that really the underlying etiology was pain, undertreated pain. So this is the busy slide. I apologize. So I had the pleasure of working with her in our perinatal SUD clinic, where she shared that this was an unplanned but desired pregnancy with her partner. She came on, now 5 months pregnant. She was on 50 milligrams twice daily of methadone. So again, just thinking of this woman, it was not sufficient, right? She was in withdrawal. She shared at least a one-time use of non-prescribed medication. We did a lot of counseling on pregnancy physiology and how really impossible it would be to capture her just level of opioid dependence as an outpatient, and sort of she reached the maximum prescribing essentially for methadone as an outpatient. I don't know other states, but it caps out usually around 100, 120. And really, trying in a patient-centered way to share that being in an opioid treatment program was really the best way for her to rapidly stabilize. And so spent a lot of time really working with her on readiness to sort of accept the diagnosis of OUD and go to an opioid treatment program. Eventually, before she was sort of committed to that, she did come back inpatient, which we had offered her to manage uncontrolled pain. Again, it was really sort of a complicated case. Was this underlying chronic sickle pain? Was it acute pain crisis? Was it those two things plus, the underlying opioid dependence? And from the prior non-prescribed use, she ended up having a really complicated course, required ICU level care for pain management with a lot of drips, a lot of PCAs, and a lot of and ketamine. She at that time had up-titrated her methadone to 80 twice daily, again linked to the opioid treatment program, again due to sort of being new to this treatment system, as well as all the things that that go along with needing to go to a new place. Struggled to actually come in at the right time where the doctor was there, so she could get actually be formally admitted and not just be sort of continued without any dose titration. And then finally shared that she'd actually been taking prior prescribed methadone pills because she had gone in the past. She was taking 300 milligrams a day actually on her own. So she wasn't at the OTP, and she was just really self-managing her pain and with this. And so thankfully we were able to readmit her for what was an acute pain crisis. Complicated, all the complications that you get in pregnancy, right? So she ended up having cholestasis. She had a beautiful vaginal delivery after aversion. And then left at discharge in methadone of 150 and 100. Breastfed during the time that she was in the hospital, did have a CPS filing for active use, and they felt they needed to remove custody emergently, which was really challenging for this mom. And so thankfully we ended up again readmitting her because of her uncontrolled pain in the setting of trying to get to court to her 72-hour hearing, right, to be able to sort of navigate the other pieces of life. She was titrated to 170, 120 split dose. You can see again, that's still not the 300 that she sort of had been managing on her own, but felt a lot better. Did discharge to a residential program with a 60-day letter, and continued to actually pump breast milk during the separation. Has stayed on that dose of methadone and was recently reunited with her daughter and is doing phenomenally well in residential treatment. And so that was a whirlwind through a complicated case, but I just wanted to highlight some of the pieces that made it so complicated, right? So this is not uncommon, right? This is someone who really sits with undiagnosed opioid use disorder because of real fear of the medical system. It turns out that her own trauma history includes parents with a history of SUD, limited social supports, living with a chronic illness right from childhood. And it really, it took a lot of time to build trust given that. And, we always say that the pregnancy timeline isn't always the same as the substance use timeline. And so it took time to gradually accept the diagnosis of OUD and the benefits of engaging with the addiction treatment system. Again, thinking about the challenges in our system, getting her to be able to complete this admission with a doctor at the OTP who was only there once a week was incredibly hard. And actually the telehealth flexibilities are what finally saved us because, with our seeing this patient every week, even though the treatment program was probably like 6 blocks away, she just couldn't make it happen. And so being able to do a video telehealth to finalize the admission was pretty essential. again, this is someone with incredibly high opioid dependence due to sickle cell. And she was never really titrated to the effective dose in the hospital for a number of reasons, right? She was simultaneously getting treated for pain with short-acting opioids. She was ambivalent as to whether she needed such a dose, and again, her liver was ramping up in her pregnancy throughout that time. And I think this case really required tremendous collaboration between all of the different players in order to stabilize this complex patient, right? So our addiction consult team, our sickle cell team, the methadone, the residential program, our outpatient clinic. And so sharing that because it ended up being a beautiful success story and a complicated system that would not have been possible to actually navigate without sort of all of the players involved. So with that, I'm going to stop sharing. And I see Nika already raising her hand. That might not have been intentional, but
Oh, I know it was intentional. Is that okay? I thought I really wanted to appreciate you for sharing such a complicated case, because these are like the real life stories that happened. So first of all, thank you. That was such a tragic and heartbreaking, and also thank you for there also being a beautiful, happy ending. And I just wanted to acknowledge like how hard it is when there is a removal and a separation, and for people to stay in treatment when that happens. So so many kudos to your team for advocating, and especially to the patient for sticking with it. My question for you is, and actually for everyone on the call, kind of connection. I'm not sure it's not directly this case, but I was reading into it a little bit, which is that we are struggling with kind of two phases of admissions. When we're stabilizing someone, like really helping them to tolerate the hospital, which it sounds like your team was doing in the ICU with drips and all kinds of like complicated maneuvers. And then moving from that to like, okay, now we're prepping for the program setting where someone's sedation level needs to be low enough that they can engage in groups and do all baby care and not be triggering to other people in what are often small residential treatment programs in our setting. We again have like started that stabilization phase with like very aggressive short-acting opioids because we had been really losing people. And so I feel like we're doing a much better piece of that. But then that second piece, which we're now trying to explicitly name with patients, of sometimes kind of titrating down, especially postpartum, even that transition, like we tolerate a level of sedation during pregnancy that's different postpartum, we are really, really struggling with. How to frame that with patients, how to frame that with our addiction care team, who might not be as familiar with the needs of baby care and what happens when you haven't slept for 4 days and are sedated at 3 o'clock in the morning and things like that. So I'm curious how you approach that, and if that period, in this case, it sounds like the patient was separated from her baby for a period of time, which maybe would have been a period to kind of for that to happen. But had it not, how do you deal with that? And do you have any strategies, or does anyone have any strategies on the call? How to
I'm
help
happy to start and
patients?
pass
Yeah.
it along. Yeah, no, I think it's so important. And it is something that I bring up, and I start bringing up in third trimester and like planning for postpartum, and talking about the fact that, right, you're gonna be exhausted. And so the methadone is just gonna be additive, and we need to watch it because we talk about sort of the audition, right? So actually we worry about this in the hospital when people are making, immediate sort of assessments of a mom's ability to parent, and she's 2 days post-op from a C-section on methadone, and, like at her worst, right? And where it's like, okay, we have to decide if, we've never met you and we're deciding if you can parent. And so I think there's that moment in the hospital, and then there's obviously being able to care for the baby at home. And I'm pretty direct with that, like, this is something that like we have to really keep an eye on. And I talk to everyone every single time about like, what does it feel like at peak, what does it feel like, it's sort of and really encourage them to pay attention to that too. And in this case, she did have peak sedation, and it impacted her ability to be in groups. And so, we talked every week, we saw her every week and followed up on it. And she said that, yeah, I'm actually having trouble staying awake in group. And we shifted the timing of her methadone, actually. We've been playing a lot around with it. So she stayed on BID. And she used to take it at like 8 a.m. and 8 p.m. because she's at a residential, right? And that's when it's given. And then it would peak during group. And so it was like the 10 to 12. And so she's like, I'd rather just take it at noon and at 8 p.m. and get through it. And so I talked about actually it's a weird split. So I talked about actually shifting, more to the evening and other ways, but she really felt like that made a difference. And so actually on the weekends, she like goes back to the 8 a.m. But during the week, she, so this is like letter after letter, right? Of like work with him. And then she happened to get lucky that this is, the variability of residential treatment in our state. This is a wonderful program who really didn't shame her for it. And I think was very compassionate in how they brought it up, because a lot of places, immediately blame it on the methadone or accuse you of using. And so I think that's some of the pieces. But we also talked about reunification. I was like, you're going to lose sleep. You're going to be exhausted. Like, this is another place where you're going to have to really pay attention to your dose and if you need to adjust it. That was
And
a lot by it. Yeah. Others?
I will add to Jess everything that she said and the importance of starting the conversations as early as possible while people are still pregnant. And when they admit in the hospital, having that conversation in triage or any postpartum or on the L&D to allow people to feel safe, but also to know what expectations they can have. Sedation is so normal when you just deliver it, and the ability to be there every day to assess, to evaluate, sometimes having the conversation whether people would like to stay on the same dose versus decreasing the dose, to know that they have choices and options. I usually have that conversation with patients, and I notice that people usually want to stay on the dose that they have been on, which with the right support does not create sedation. And if it does, then they decide that they would like to choose to go down. And also the linkage to care, the ability for you as the doctor to call the OTP director or medical provider and advocate and say, these are the adjustments, or the patient is on the same dose. We are recommending for them to stay on this dose rather than trying to decrease much faster, because I find that OTP sometimes they might decrease without the patient actually wanting to decrease.
That's so interesting, because our experience is a little bit the opposite, because they are staying on a high dose because our patients are saying, I need more. I'm in withdrawal. They're like gritting their teeth to make, and these are patients, just for transparency, who have been using up to birth and are transitioning at that time, which often haven't had a transition period. And so they are like struggling to make it in program and are sedated and are with their baby. And it is just this challenge that, they're saying they won't stay in program without their baby. If we admit them, we can't admit them for longer, but it's just this really complicated place. And I appreciate everything about the guidance in advance. And I just feel like we need more time to have people sometimes in higher levels of care together, which we struggle to do because of a gazillion different structural barriers.
Nika, are they in residential? Is that what you're saying?
So people are going to residential. And, our residential programs are very comfortable taking care with people with quite a bit of sedation, and they still need to do baby care. And so, we've just found that like window of like the appropriate levels of sedation where someone is also comfortable enough to stay in program is extremely narrow, especially when people have methamphetamines on board as well and they're washing out. So there's this other level of sedation that, it's just we're really struggling.
It's called compassion stay, 5-day postpartum floor stay, where we keep the mom for 5 days.
Yeah.
Really. Yeah. We see Lauren raising their hand.
Hi, everybody. Thanks so much. I needed this talk today because I've been really fighting it with our, even in I'm at HCMC in Minneapolis, we have a OTP in our hospital. And I'm fighting with my same colleagues around how do we navigate this together. So it's helpful for me to hear a little bit about like the larger work that you're doing across the state and getting OTPs more comfortable with higher dosing. Some 2 points that I've had pushback on lately, I just love ideas. One is I've been actually using more of the Swedish protocol in terms of like how we can do rapid methadone initiation in the hospital, which is far more aggressive, I think, than any other place right now in Minnesota. But my colleagues in the OTP are like, well, we're not going to necessarily honor that when they come back to our OTP because of the stabilization dose being 3 to 5 days after that when you're finally getting to that place. So even if I get them to a place where they're on, 80 and I'm discharging them with that 3-day supply, because of the concern for that stabilization of the dose being 3 to 5 days after, they're really anxious about that. And this is when people die. And so that's one thing I just want to I need help with that. And I am printing your papers, folks, and working on a more of a full S bar and how we make this change. But so that's one. My second thing is I have more and more people who even get to a dose in the outpatient OTP of around 120. They're still using high risk IV ongoing use and really struggling that the OTP is not going up fast enough on their methadone dose. And I noticed both of you have a 5 to 10 milligram increase every 3 to 5 days, kind of after that rapid stabilization. Anybody else doing faster? I've been bringing people in and doing a few days admission so I can do observed faster dosing and sort of going, I do 10 each day plus 5 every 6 hours, watching oxygen sats and all of this. But of course, my same colleagues are thinking I'm really going crazy, and I just love some ideas on how other folks are navigating that.
We have to do that inpatient too. If certain OTPs aren't going fast enough, thankfully there's a pregnancy privilege that we can admit them for this. So I think that's been what we need to do too. And some OTPs just won't work with I think it's been really sort of challenging. And that's where we brought the state, we being broader, brought the state together to really showcase what different OTPs are doing and hopefully bring up the sort of level so that they're actually communicating with others. Yeah, but it's a great point. But I do have colleagues at OTPs, again, if it's on a split dose, to go by 20 in a day, right, 10 on each side. Again, because think about it, right, they're rapidly metabolizing. And so, but I do think that's, it's a very future-oriented, excellent colleague.
Do you have a specific protocol for people who are already above 100, 150 as to how fast you have been able to comfortably get people up and that the OTP directors continue that same dose after stabilization?
We actually find that the pushback for some of the OTPs, the more conservative ones, it's that they don't, it's that our addiction team doesn't keep them in the hospital long enough for those 3 to 5 days at a stable dose. So we found it actually sometimes better to just go up really fast and then keep them on that dose for 3 to 5 days to show that they're not sedated on it, right? But it has been, that can be, I've seen that challenge too.
We do very similarly and offer the same protocol, and there are a lot of benefits from that. Admitting with high risk pregnancy diagnosis allows you to be on the antepartum floor or med-surg floor, and within 3-5 days you can stabilize people and also offer warm handoff with linkage to care.
I think because it's so also OTP medical director dependent, I find that the Rolodex of meeting and having relationships with these people is critical because they need to be reassured that they trust you and that you've seen and evaluated this person, and you can sort of vouch for the fact that you're not, handing them a total nightmare, but something that's been really thoughtfully sort of done. And that's been really helpful in a lot of these cases. It's just, sort of plugging holes in a system that should, be addressed as a, right.
And I realize we are over time, so thank you so much for coming. And as you can see, we are passionate about it. Maybe we can have a follow-up, okay? visit, and reaching out to the OTP directors to have a meeting with them and offering your cell phone number works miracles. So thank you again, Jess. I so much appreciate your leadership, and
Thank you.
what a
Vania.
wonderful way to co-present.
Thank you, everyone, for coming. We appreciate you.
Thanks all.
And thank you, Caitlin, for setting this up for all of us. We appreciate it. Thank you.